Hello, fellow warriors. Here we are with news from the website, prostatewarriors.com.
It's great to be here.
So have you ever wondered what a pill, typically used for Alzheimer's disease, microscopic acoustic sound waves, and a literal treadmill all have in common?
It sounds like the setup to a joke, honestly.
Right. But today, they are all distinct weapons on the absolute bleeding edge of prostate cancer research. Welcome to the deep dive. We've taken a massive stack of recent source material for you, everything from clinical trial data to, preclinical laboratory breakthroughs, and we're synthesizing the 10 distinct updates you actually need to know.
And it really is a fascinating stack of research today because it spans the entire life cycle of how we understand and treat this disease.
Yeah, it's a lot to cover.
It is, yeah. So to make sense of it all, there's a logical flow we need to follow. We are going to start right at the front lines looking at clinical trials first.
Because those represent the therapies closest to routine patient access, right?
Yeah. Exactly. We have to look at clinical trials first. Then from there, we'll move into real-world observational data to see how those treatments actually perform out in the wild. And finally, we'll look over the horizon at preclinical breakthroughs, exploring everything from those sound waves you mentioned to exercise.
I can't wait to get to the treadmill part. But let's start on those clinical front lines. The first major update on our radar is the Phase 3 Triton-3 trial.
Right, the Triton-3 trial.
Yeah, and this involves a drug called Rucaparib.
Yeah.
It's being evaluated for metastatic castration-resistant prostate cancer, specifically in patients who have a BRCA mutation.
And, metastatic castration-resistant prostate cancer and mCRPC, that is that notoriously difficult stage where the disease just continues to progress despite heavy hormonal suppression.
Right, it's the really tough stage.
It is. And the patients in this specific trial were chemotherapy naive, meaning they hadn't undergone traditional chemo yet, but their cancer was progressing after one prior androgen receptor pathway inhibitor.
Okay, so they've tried the hormonal route, it's failing, but they haven't done chemo.
Precisely. Now, the efficacy of Rucaparib is well documented, but what the Triton-3 data really forces us to unpack is the safety profile.
Because when you're looking at advanced systemic therapies, the quality of life calculation for the patient is just as important as the clinical outcome.
Right.
So what does the toxicity actually look like here?
Well, it's a pattern that's very characteristic of the PIRP inhibitor class. It's largely driven by hematologic effects.
Meaning it impacts the blood and bone marrow.
Right, heavily impacting the blood. Fatigue was the most common adverse event, showing up in over 60% of patients. But more critically, the trial reported a 46% rate of anemia.
Wow, 46%.
Yeah, and of those, 28% of patients experienced a drop in red blood cells so severe that they actually required blood transfusions.
Wait, 28% needing transfusions? That's substantial.
Yeah.
If I'm a patient hearing that, my immediate thought is that this drug sounds incredibly harsh on the body.
It sounds alarming, absolutely. But the context of the data tells a slightly different story. Because despite those high anemia numbers, the discontinuation rate of the drug was remarkably low.
Oh, really? How low?
Under 14%. Furthermore, the risk of severe long-term bone marrow complications like myelodysplastic syndrome or acute myeloid leukemia was only 1%.
Okay, so it's happening, but it's not causing them to stop the treatment.
Exactly. The takeaway is that while the anemia is significant, it's also highly manageable if the oncology team is monitoring blood counts proactively.
So it's a completely different philosophy of treatment compared to traditional systemic chemotherapy.
How so?
Well, with standard chemo, you often have this scorched earth acute toxicity where you're essentially blasting the whole system. But utilizing Rucaparib sounds much more like managing a chronic long-term supply chain issue.
That's a great way to put it.
Yeah, like you have to tend to the patient's hematologic health, like you're tending a garden, carefully monitoring it, occasionally adding fertilizer, or in this case, a transfusion rather than just burning the whole field to the ground.
That captures the clinical reality perfectly. You are chronically managing the environment so the targeted therapy can continue doing its very specific job against those BRCA-mutated cells.
Makes total sense.
Now, staying within the realm of immediate clinical impact, our sources also highlight a major shift happening in how we actually visualize the disease.
The imaging side of things.
Right. There is compelling data from a Phase 2 trial evaluating a new PU imaging tracer known as 61CU NU101.
Okay, I definitely want to dig into this because advanced imaging is everything when it comes to staging and treatment decisions.
It really is.
So in this trial, they compared this new 61CU NU101 tracer against the current standard, which is 18F-biflufalestat. Well, a lot of people just know it by the brand name Pylarify.
Right, Pylarify.
So what is the actual advantage of this new copper-based tracer?
It essentially comes down to the physics of radioactive decay. So Pylarify has a half-life of about 109 minutes, but the new 61Cu NU101 tracer has a much longer half-life of 3.3 hours.
It lasts almost twice as long in the body. I assume that buys the clinical team a lot more flexibility.
It completely changes the logistics. With a 3.3-hour half-life, a central manufacturing hub can produce the tracer and ship it significantly further distances before the radioactivity degrades.
Oh, wow. So that drastically expands access for patients who don't happen to live right next door to a major radiopharmacy.
Exactly. But the clinical advantage for the individual patient is even more profound because it allows for delayed imaging.
Meaning they don't have to rush the patient into the scanner immediately after the injection.
Yes, exactly. With standard tracers, you generally image the patient about an hour post-injection, but with 61Cu NU101, you can wait 4 hours.
And what does that extra time do?
Giving the tracer that extra time to circulate allows it to accumulate in micrometastases. Those are lesions that are incredibly small, as well as in tumors that have very low PSMA expression.
So it finds the stuff that's hiding.
Right. The phase 2 data clearly demonstrated that this delayed imaging revealed lesions the standard tracer completely missed. And recognizing those hidden lesions is crucial because of how this tracer fits into the concept of theranostics.
Theranostics, the strategy of pairing a diagnostic tracer that sees the cancer with a therapeutic isotope that actually treats it.
Exactly.
So does this new copper tracer have a therapeutic partner?
It does. 61Cu NU101 forms a theranostic pair with an isotope called 67U.
Okay.
It operates on the exact same principle as the widely known standard, which is 177 Lu PSMA 617. You use the 61Cu version to light up the map, and then the 67Cu version to deliver the radiation payload. The breakthrough here is precision. If the delayed imaging of the copper tracer can illuminate tiny micrometastases that older methods are blind to, the therapeutic copper isotope can then be deployed to destroy them. The net is cast much tighter.
That is a massive leap forward for precision medicine. Now, there's one more clinical trial in our staff.
Yeah.
And this is the one that genuinely made me do a double take.
Oh, the Memantine trial?
Yes. It's a phase 1 trial for a drug called Memantine. And for anyone familiar with neurology, Memantine is a well-known medication used to manage symptoms of Alzheimer's disease.
Right.
How on earth does an Alzheimer's drug end up in a prostate cancer trial?
I know, it sounds crazy, but it really highlights how creative oncology is becoming with drug repurposing. This phase 1 trial is applying Memantine to neuroendocrine prostate cancer, or NEPC.
Which is really bad news, right?
Very. It's a highly aggressive, treatment-resistant variant of the disease. What researchers discovered in the lab is that Memantine happens to block a specific signaling pathway called the HOXD11-NMDAR pathway.
Wait, but why does a brain signaling pathway matter in a prostate tumor?
Because prostate cancer cells use that exact pathway to perform a biological magic trick called lineage plasticity.
Lineage plasticity.
Yeah. When a standard adenocarcinoma is placed under immense pressure from our best hormonal therapies, the cancer realizes it's going to die. So, to survive, it flips a switch. It literally sheds its normal prostate characteristics, turns off its androgen receptors, and morphs into neuroendocrine prostate cancer, which doesn't rely on hormones at all.
So it literally changes its disguise to evade the drugs entirely. And Memantine stops that.
The data suggests it interrupts that specific switch. By blocking that pathway, Memantine prevents the cancer from changing its identity, keeping it in a state where our therapies might still work.
That's incredible.
It is. In fact, this phase 1 trial already reported an early clinical signal of radiographic regression in one patient. Now, it is very early, but the biological mechanism is a completely novel way of cornering the disease.
But, you know, if we can't always stop these aggressive mutations from happening like Memantine is trying to do, how are we handling the patients whose cancer has already evolved before they even start treatment?
That's a great question.
Because that seems to be the focus of the real-world data in our sources.
It is, and that's a vital transition to make. Clinical trials are controlled environments, but real-world observational data shows us the messy reality.
Right.
We have a study looking at 745 U.S. patients with metastatic castration-sensitive prostate cancer. The researchers segmented out patients who harbored homologous recombination repair alterations, the most famous of which are the BRCA1 and BRCA2 mutations we discussed earlier.
Yeah, we know BRCA mutations drive highly aggressive disease. So how did these patients fare on standard frontline therapies out in the wild?
Honestly, not well. When treated with standard androgen receptor pathway inhibitors, or ARPIs, the patients with BRCA1 or BRCA2 mutations progressed rapidly.
More rapidly.
Well, for patients without those genetic alterations, the median time to next treatment was 27.2 months. But for the BRCA-mutated patients, it was only 19.6 months.
Hang on a second. If we connect this to what we just discussed regarding the Triton-3 trial, we already know PRP inhibitors like Rucaparib are highly effective against BRCA-mutated cancer.
Right.
So if we know these real-world BRCA patients are progressing, almost 8 months faster on standard ARPI therapies, shouldn't we be giving them PRP inhibitors immediately? Rather than waiting for them to become castration-resistant?
You hit the nail on the head. That contradiction is exactly what this observational data exposes. You've identified a massive real-world treatment gap.
Because the standard playbook is failing them.
Exactly. Our standard frontline protocols dictate starting with hormonal therapies. But if the biology of the tumor is inherently resistant from the start due to a BRCA mutation, those standard protocols are setting the patient up for rapid failure.
So we need to act faster.
It argues strongly for moving targeted therapies much earlier in the treatment sequence.
It definitely highlights the need to understand the individual biology before just, throwing the standard playbook at the wall. But when it comes to standard systemic therapies, the real-world data isn't all bad news, is it? What about the patients taking oral ADT?
Ah, you're referring to the OPTYX study. And yes, this is incredibly encouraging. This looked at 999 real-world patients taking Relugolix, which is also known as Orgovyx.
The oral pill.
Right. It's an oral form of androgen deprivation therapy, meaning the patient takes a pill instead of receiving the traditional depot injections.
And did it work?
The primary success was obvious. Over 92% of patients achieved deep castration levels of testosterone, meaning under 50 nanograms per deciliter at the 6-month mark.
Okay, so the efficacy is clearly there. But from a patient perspective, the most compelling part of this study was what happened when they actually stopped taking the pill.
Yes.
Because giving the body a break from chemical castration is a huge quality of life issue.
The recovery data really is the breakthrough here. When patients discontinued Relugolix, their testosterone recovered remarkably fast. It bounced back to a mean of 214 nanograms per deciliter within just 3 months.
That's fast.
It is. But, and this is the critical balancing act, while the testosterone came back, the PSA stayed suppressed.
Wait, really?
Yeah. Even at 6 months off therapy, 66% of patients still had a PSA below 0.2.
That is the ultimate win-win scenario, because the testosterone returns, which brings back the patient's energy, it helps preserve muscle mass, lifts the mental fog, but the cancer marker remains flat.
Exactly.
It seems like this makes the concept of intermittent ADT, like taking intentional scheduled treatment holidays, much more practical.
It makes it highly viable because the oral administration gives the oncologist granular control. You can turn the suppression on and off like a light switch rather than waiting months for an injection to wear off.
Which is huge for patients.
Huge. But while systemic control tools like Relugolix are getting better, our preclinical sources remind us that the tumor is incredibly resourceful.
They always are.
Right. It doesn't just sit there and take it. It actively manipulates its local environment to fight back.
You're talking about the tumor microenvironment. It's not just a collection of cancer cells. It's an entire ecosystem they built to protect themselves. So how are they resisting these systemic therapies on a local level?
This is where the biology gets really devious. Preclinical researchers ran a massive secretome screen to see what proteins were being secreted in and around the tumor.
Right.
They zeroed in on a protein called Neuroendocrine, or NRG1. But here's the catcher. The cancer cells aren't the ones making it.
Then who is?
The cancer essentially hijacks the surrounding healthy-looking stromal cells in the microenvironment and forces them to secrete NRG1.
Wow. So the cancer is literally kidnapping its healthy neighbors and forcing them to act as a life support system.
Exactly. That secreted NRG1 floats over to the cancer cells and activates a receptor called HER3. Once HER3 is activated, it provides an alternate survival pathway that allows the tumor to completely bypass standard drugs like enzalutamide, as well as experimental PI3K inhibitors.
That's terrifying. If the tumor has built this alternate supply line using the healthy cells, how do you cut it off?
The researchers proposed a triple threat approach. You have to hit the androgen receptor with enzalutamide, you hit the PI3K pathway with an inhibitor, and simultaneously you deploy an anti-AR3 antibody like a drug called seribantumab.
To intercept the signal.
Right, to intercept that NRG1 signal coming from the neighbors. You basically have to block the front door, the back door, and the windows all at once.
That level of multi-pathway blockade makes total sense. And speaking of cutting off the tumor's resources, our sources also detailed a fascinating mechanism involving a drug called Tipifarnib.
Yes, in models that are highly resistant to enzalutamide.
Right.
In those resistant cell lines like 22RV1 and CWRR1, Tipifarnib isn't acting as a direct killer of the cancer cells. Instead, it's acting as an adjunct, a helper drug. The data showed it reduced the release of exosomes from the cancer cells by about 30%.
Now, exosomes are essentially how cells communicate, right?
Yes.
So it's almost like these exosomes are tiny, encrypted USB drives that the cancer cells pass back and forth to share the genetic cheat codes for surviving enzalutamide.
That's a great analogy.
Is Tipifarnib basically acting like glue in the USB ports, shutting down their communication network so they can't upload the resistance codes to each other?
That is exactly the mechanism. It suppresses their communication network, isolating cells so they can't coordinate their resistance.
Incredible.
Now, Tipifarnib represents a chemical disruption of the tumor's defenses, but the next preclinical breakthrough in our stack abandons chemistry entirely. It uses raw physical force. We are talking about acoustic cavitation.
Microscopic sound waves.
Yes.
And this is being tested against that same aggressive neuroendocrine prostate cancer we discussed earlier with the Alzheimer's drug. But how on earth are they using sound waves to fight a tumor?
The technique involves taking nanometer-scale lipid microbubbles and injecting them into the patient's bloodstream.
Okay, bubbles in the blood.
Right, and these bubbles naturally circulate through the tumor's blood vessels. Then the clinical team targets the physical tumor mass with focused ultrasound. When the sound waves hit those tiny bubbles, they rapidly expand and violently collapse.
Oh, wow. So it's creating microscopic shockwaves right inside the tumor's infrastructure.
We call it synoperation. That physical force literally punches temporary holes in the cancer cell membranes and breaks down a critical tight junction protein called claudin-3.
Which does what?
The tumor uses claudin-3 to hold its defensive walls together. By blowing the doors off, it obviously makes it easier to deliver chemotherapy into the cell. But the most profound effect isn't actually about drug delivery.
What is it about?
It's about oxygen.
Wait, oxygen? But what does oxygen do to a tumor? I would think supplying a tumor with oxygen would make it grow.
You'd think so, but actually the opposite is true for aggressive solid tumors. They thrive in hypoxic, extremely low oxygen environments. Hypoxia drives aggressive mutations.
I see.
So by physically tearing the tumor architecture apart, cavitation forces oxygen back into the tissue. This rapid reoxygenation causes a massive drop in hypoxia-driven survival proteins like HIF-1 alpha, NSC, and MYCN.
So it weakens them.
It weakens them, and it simultaneously raises the level of natural tumor suppressors like PTN.
It's essentially suffocating the cancer by forcing it to breathe fresh air.
Exactly, and that fresh air completely alters the immune landscape. You see, NEPC is typically an immunologically cold tumor.
Meaning it's invisible to the body's immune system.
Right. But this physical destruction and reoxygenation turns the tumor hot. The area suddenly becomes flooded with CD8 plus T cells, which are the immune system's primary killer cells. The sound waves physically prime the tumor for immunotherapy.
Going from an invisible tumor to one swarming with killer T cells just by vibrating microbubbles is, it's phenomenal.
It really is. Now, before we get to our final and perhaps most relatable study, there is a quick genetic update we need to touch on regarding how these cells alter their physical structure.
Okay, let's hear it.
Researchers have mapped a newly discovered genetic driver called ZNF281. It acts as a co-activator for the androgen receptor, but its real danger lies in how it promotes a process called EMT via a protein called SNEL.
EMT, which stands for epithelial mesenchymal transition.
Yes.
For those who aren't biologists, EMT is basically the process of shapeshifting. A normal prostate cell is like a brick. It's meant to stay in the wall. EMT is when that brick mutates into a fish, allowing it to detach from the tumor, swim into the bloodstream, and metastasize to the bones.
A very apt description. ZNF2A1 is the driver pushing that shape-shifting process. But the good news is that researchers have already tested a new rhodonine-based inhibitor targeting ZNF281.
Did it work?
It did. In patient-derived organoid models, it actually outperformed standard enzalutamide. It's a prime target for stopping metastasis right at its source.
Okay, so we have covered copper isotopes, Alzheimer's drugs, chemical communication jamming, and microscopic shock waves.
We have.
But we have to conclude this deep dive with what is undoubtedly the most accessible preclinical study in our entire stack. It doesn't require a particle accelerator. It requires a treadmill.
Ah, yes. We are looking at the molecular impact of voluntary exercise. Researchers utilized a pin knockout mouse model.
And those are mice genetically engineered to spontaneously develop aggressive prostate cancer, right?
Exactly. And they simply gave half of these mice access to running wheels in their cages.
Well, the mice that ran obviously got the cardiovascular benefits, but what actually happened to their tumors?
The physical exercise cut their tumor proliferation by more than half compared to the sedentary mice.
Okay, I have to ask the obvious question here. We all know exercise makes you healthier. Were the tumors shrinking just because the running mice lost body fat and had better general metabolic health?
That is the exact assumption the researchers wanted to test. And the answer was a definitive no.
Really?
Really. The anti-tumor effect occurred despite there being absolutely no differences in body weight between the exercising mice and the sedentary ones. The mechanism driving the tumor suppression had nothing to do with weight loss. It was entirely molecular.
Wait, so you're saying that the physical act of exercise is functioning mechanically inside the body, exactly like a targeted oncology drug?
Precisely. Through complex metabolic analysis, the researchers discovered that the physical stress of exercise caused a marked suppression of an enzyme called Arginase 1, or ARG1.
And why does ARG1 matter?
To understand that, you have to look back at the tumor microenvironment. The tumor uses ARG1 to actively deplete the surrounding tissue of arginine.
Which is an amino acid.
Yes, an essential amino acid. And your immune system's T cells absolutely require arginine to function.
Oh, I see. So the tumor is essentially starving the immune system of its primary fuel source, so the T cells are too weak to attack. And the exercise stops that enzyme.
Yes. The exercise suppresses ARG1. By suppressing that enzyme, the arginine levels remain high, the fuel supply is preserved, and the immune system remains fully active and capable of fighting the cancer.
That is wild.
And they proved this definitively. When they gave the sedentary mice an experimental chemical arginase inhibitor drug, it achieved the exact same tumor shrinking effect as the running wheel.
Wow.
And when they combined the chemical drug with exercise, there was no additive benefit, proving beyond a shadow of a doubt that the exercise and the drug were utilizing the exact same molecular pathway.
That completely reframes how we think about lifestyle interventions. When a doctor tells a cancer patient to try and get some exercise, it's not just vague wellness advice to help them feel better anymore.
Not at all.
You're saying exercise is functioning mechanically exactly like a targeted arginase inhibitor drug. It is a biological directive to actively preserve the metabolic fuel supply for their immune system.
That's exactly right. If we synthesize this entire deep dive, the overarching theme is that understanding and treating prostate cancer requires us to view the disease through multiple interconnected lenses.
Yeah, from the micro to the macro.
Exactly. We are manipulating the atomic level with the physics of 61Cu in U101 tracers. We are physically tearing apart the tumor's cellular architecture with acoustic microbubbles, and we are harnessing the sheer, measurable metabolic power of physical movement to alter deep immune pathways.
Which brings us to a final provocative thought for you to ponder as we wrap up today. We've just seen the irrefutable molecular data on how physical exertion suppresses arginase 1 to fight tumors. Could the future of standard of care oncology be a highly personalized, multidisciplinary prescription?
It's entirely possible.
Imagine a treatment plan that requires you to take a targeted oral pill, receive a precise theranostic isotope injection, and complete a strictly monitored, highly specific 45-minute workout routine. Treating your physical exertion with the exact same clinical rigor, precise dosage, and medical expectation as a chemotherapy infusion. The science suggests that is exactly where we are heading. Stay strong and fight on.